Hi, I'm Dr. Perry Shieh from the Department of Neurology. Today I'm going to be talking to you about Duchenne muscular dystrophy, the diagnosis and management. So I think this lecture is really to give you a little idea of how a clinician sees these patients. And so I think as a good starter, it would be nice to see, to give you a case, to give you a little idea of how these patients look when they come in to see me. So this case here is a 6-year-old boy at the time when he came to see me, and he was walking a little funny, according to the parents. But he was first noted to be perhaps not quite normal at the age of 2.5, but it was actually a problem with speech. The parents said that he just wasn't speaking very well. And by 2 years and 9 months of age, the school district actually began providing speech therapy and language therapy. At the age of 3, he was only able to speak 2 words. But by the age of 4, he was starting to catch up and he was speaking full sentences. The family was told by a number of clinicians that he had some type of mixed expressive and receptive language delay, but that was all that they were told. He was also noted to have some mild autistic features. He would not walk on the sand or grass because of how it felt. He had obsessive and compulsive type of features. For instance, he would not tolerate smells or sounds, and he was very rigid and would often have outbursts if things did not go his way. And because of these behavioral issues, he was started on ADHD medications at the age of 4. He had some other evaluations, just general medical evaluations at the age of 5, and it revealed some abnormal liver function tests. And based on this, they proceeded with a liver biopsy to see if there was something wrong with his liver, but that was normal. Patient's parents did notice that he was walking a little bit funny at the age of 4, but it was thought that this was probably from his autism, that he was kind of intolerant of certain sensations on his feet. But by the age of 6, it was clear that he was actually a little bit slow to get up from the floor, and he was using hands for support. And because of this obvious weakness, muscle disease was suspected. And so a serum CK test was ordered. It was quite elevated at 27,400. Normal should be about 200 or less. So looking back at his motor development, he was sitting at 8 months of age, crawling at 10 months of age, walking by 18 months of age. This is perhaps slightly slow, but pretty much within the range of normal. Weakness was perhaps in retrospect thought to be very mild. He was able to participate in a number of different activities, karate, tennis, soccer, but he was usually the slowest kid on the team. And parents noticed that he had large calves, as you can see right here, but the parents thought that perhaps he was just very strong and did not realize that this might actually be something that's been associated with muscular dystrophy, what we call pseudo-hypertrophied calves. Past medical history, just basically everything I've just told you. He has this autism, he has mild speech delay, and then more recently it was noticed that he had some weakness. There's no family history, nobody in the family who had neuromuscular disease as far as they knew. He had 2 siblings, an 8-year-old sister and a 3-month-old brother. The family support and environment were very good. This is a review of some of these laboratory studies that I already told you about. The AST and ALT are the liver function tests. They should be less than 30, and you can see that they're markedly elevated. And the CK, as I told you earlier, was 27,400, which should be around 200. So based on this story, it seemed pretty clear to the neurologist that saw him at this time that he may have Duchenne muscular dystrophy. And genetic testing was sent, and it revealed a deletion of exon 50. And this resulted in a predicted phenotype of Duchenne muscular dystrophy. So Duchenne muscular dystrophy is a disease of boys who have a mutation in this gene that's called dystrophin. Because of their inability to make the protein dystrophin, their muscles degenerate through time. On this slide here, you can see that dystrophin is illustrated as this yellow protein that appears to link the intracellular cytoskeletal elements, the actin filaments, to this membrane-bound complex that's called the dystroglycan-associated glycoprotein complex. And if you stain for dystrophin in muscle, this is what it would look like in a normal patient. In a patient who has Duchenne muscular dystrophy, it would show absent staining. So the clinical progression of the disease, patients usually present with some walking problems, and there's some variability. Sometimes they present a little bit later, as this boy turned out to be. But at some point, they lose the ability to walk and they have to enter a wheelchair. And then there's limited use of arms, and eventually they cannot feed themselves, they cannot breathe on their own, and they would require ventilation, and this ultimately would result in death. It's an X-linked disease, so this is really a disease that predominantly affects boys. So there are a few things I want to discuss here. For the remainder of this part 1 lecture, I would like to talk about the consequences of delay in diagnosis, and I would also like to talk about testing in the mother. In part 2 of this section, we'll talk about why the gene mutation results in a predicted phenotype of Duchenne. In part 3, we'll talk about standards of care for Duchenne muscular dystrophy. So diagnosis, we really want to make the diagnosis as early as possible because that allows us to be able to start certain treatments like steroids and stretching, because this will prolong the ambulation for the patient. Steroids help with strength. It improves the strength of these muscles. It reduces the slow deterioration that we see in the muscle. And stretching helps to maintain the flexibility that's required for a patient to be able to continue to walk. The mother also has this 3-year-old boy, and she did not have the opportunity to take any measures to avoid having a second child with Duchenne muscular dystrophy. It's subsequently been shown that this child actually does not have Duchenne muscular dystrophy, but of course, if he had, then she would not have had any opportunity should she have wanted to avoid this pregnancy. There's a study in the United Kingdom that was recently published talking about collectively how long it takes for patients to be diagnosed with Duchenne muscular dystrophy. And the mean age of onset of symptoms is usually about 2.7 years of age. The patient is typically then presenting to a doctor at 3.6 years of age. A CK, that serum CK test, is sent a little bit later, and the diagnosis is usually made shortly after that. So as you can see, the typical delay in diagnosis is about 1.6 years, and this is something that perhaps we can do something about to reduce this delay. Genetic testing in the mother, it's important for us because, as this case illustrates and many other cases may illustrate, family planning is something that a lot of patients' families really want to have the opportunity to have. But it's also important to note that the mother has a risk of cardiomyopathy. And this has been studied in a number of different studies. I've illustrated 2 of them here. There's this longitudinal study of almost 200 female carriers of Duchenne and Becker. And it was noted that 45% had some level of abnormality on echocardiogram testing. And significant cardiomyopathy was noted in almost 11% of these females. There's another study that showed a 9-year follow-up of almost 100 women. It was a Dutch study, and it revealed that 11 carriers out of these 99 actually had dilated cardiomyopathy. And 3 of them had cardiomyopathy at the start of the study, so therefore 8 of them developed cardiomyopathy over those 9 years. This is a table that was taken from that study, and as you can see here, these are the 11 patients. The 12th patient actually did not have cardiomyopathy, but had some mild level of cardiomyopathy at the beginning of the study. But what I have shown here is 4 patients circled here who were actually quite young, 35, 27, 34, and 22 at the beginning of the study. And so as you can see, a number of these mothers actually developed cardiomyopathy at a significantly young age. So this concludes part 1 of the lecture. I just want to summarize that it's important for us to reduce the delay in the diagnosis of our patients with Duchenne muscular dystrophy and realize that mothers who are carriers as well as female siblings who may be carriers are also at risk for developing cardiomyopathy.